Here's one that catches people out in rapid tranquilization scenarios. Most drug combinations in psychiatry come with a caution, a consider, and monitor closely. This one doesn't. Maudsley's own rapid tranquilization guidance states plainly, olanzapine must never be combined with an benzodiazepine, not avoid where possible, never. By the end of this you'll understand exactly why that combination is singled out this way, and how it compares with what BNF itself says about the same combination. Watch this, 2 syringes side by side, olanzapine here, a benzodiazepine here, draw a big X between them, together at the same time by injection, never, that's the rule. What kind of drug is olanzapine? It's a thienobenzodiazepine, and if that sounds close to clozapine's chemical family, that's because it is. Olanzapine was developed as a structural relative of clozapine, aiming to keep some of its broad efficacy, while avoiding the mandatory blood monitoring that clozapine requires. Brand name is Zyprexa, though it's very widely prescribed generically, and formulation-wise this is one of the most flexible antipsychotics we'll cover. Tablets, a dissolving orodispersible version, a short-acting injection for acute agitation, and a genuine long-acting depot. We'll come back to that depot in detail because it has a safety requirement unlike almost anything else in this class. Licensing here has a genuinely precise structure worth getting right. Schizophrenia is straightforward, standard licensed indication. Combination therapy for mania is next, and note the word combination. It's used alongside lithium or valproate for acute episodes, not necessarily alone. And the third one is the one that trips people up. Prevention of recurrence in bipolar disorder. This isn't a blanket maintenance license for anyone with bipolar disorder. BNF is specific that it's for patients whose manic episode has already responded to olanzapine therapy. In other words, the license follows demonstrated response, not diagnosis alone. Let's start with how BNF itself describes this drug's mechanism, in its own words. A dopamine D1, D2, D4, 5-HT2, histamine 1, and muscarinic receptor antagonist. That's already a long list compared with some of the other drugs we've covered. But here's the genuinely important teaching point straight from Stahl. Olanzapine's strongest receptor potency isn't even at D2, it's at H1 and 5-HT2A. D2 antagonism, the receptor action that actually defines antipsychotic, is comparatively weaker than several of its other actions. If you've covered amisulpride in this series, remember how clean and selective that drug's receptor profile was, essentially just D2 and D3. Olanzapine is its total opposite, a broad, promiscuous, dirty drug that touches almost everything. And that breadth is exactly what explains both its efficacy and its side effect burden, which we'll build on through this deck. Now let's map that broad receptor story onto the 4 dopamine pathways. Mesolimbic blockade calms positive symptoms. Same as any antipsychotic, mesocortical is where olanzapine's extra receptor actions actually earn their keep. Stahl specifically flags 5-HT2C antagonism as a possible contributor to mood and cognitive benefit here, on top of the usual 5-HT2A story. Nigrostriatal is comparatively gentler than you'd expect, partly because D2 itself isn't olanzapine's strongest action to begin with, and tuberoinfundibular prolactin does rise, but it tends to be more transient and dose-limited than the marked, sustained elevation we've seen with risperidone or amisulpride. Keep that comparison in mind for later in the deck. Same 4 roads out of the midbrain as always. But look here, on the mesocortical pathway, olanzapine gets an extra push here from 5-HT2C antagonism, on top of the usual serotonin story. That's part of what makes this drug's cortical effect a bit different from the others. Here's the genuinely counterintuitive part of this drug's profile. When you rank olanzapine's receptors purely by binding strength, D2, the receptor that actually defines antipsychotic, doesn't come out on top. H1 and 5-HT2A do, both at the strongest affinity tier, with D2 sitting a notch below. That doesn't mean D2 blockade isn't doing real antipsychotic work, it clearly is clinically, but it tells you this drug's overall personality, its side effect signature especially, is shaped as much by H1 and 5-HT2A as by D2 itself. This is where olanzapine's dirty drug reputation really shows itself. 5-HT2C antagonism is worth pausing on. Stahl proposes it contributes to mood and cognitive benefit, but also flags it, together with H1 antagonism, as a likely contributor to weight gain. That's a genuinely important dual-edged point. The same receptor action that might help mood may also be part of the metabolic problem. Muscarinic antagonism across M1 through M5 is real here. Unlike amisulpride or cariprazine, which barely touch this receptor family, olanzapine does produce genuine anticholinergic effects: dry mouth, constipation, blurred vision. D4, D3 and D1 antagonism add relatively minor independent effects on top of the core D2 story. Alpha-1 antagonism contributes to postural blood pressure drops, particularly relevant during IM use, and 5-HT6 and 5-HT7 are proposed as minor contributors to cognitive and mood effects, though these are less firmly established. Absorption is fairly unremarkable for olanzapine. It's well absorbed orally, and food doesn't meaningfully change how much gets in or how fast. Worth a quick note on the orodispersible version, the Velitab. It's genuinely useful for patients who struggle to swallow tablets, or where there's a concern about covert non-adherence since it dissolves on the tongue. But don't overstate what that means pharmacokinetically. It's not absorbed through the oral mucosa the way some sublingual formulations are. It still ultimately gets swallowed and absorbed via the GI tract at essentially the same rate as the standard tablet. So how does olanzapine get into the brain? Primarily the straightforward way. It's highly lipophilic, classified as BCS class 2, and crosses the blood-brain barrier mostly by passive diffusion. But there's a twist worth knowing. Despite that good permeability, oral bioavailability is only around 57%, because a large proportion gets metabolized on its first pass through the liver before it ever reaches the brain. That's part of why doses need to be as high as they are relative to how potently this drug binds its receptors. Now here's where olanzapine sits differently from the other drugs we've covered in this series. It's not purely passive diffusion. Mouse studies knocking out P-glycoprotein, the same efflux pump we discussed for risperidone, showed 3 times higher brain olanzapine concentrations in the knockout animals compared to normal mice. That's a real effect, just smaller in magnitude than what's been shown for risperidone. And there's even human data suggesting genetic variants that reduce P-glycoprotein activity are linked to better clinical response, which fits, if reduced pump activity means more drug actually reaching the brain. Look at this capillary. Most of the olanzapine just slips straight through. That's passive diffusion, driven by how fat-soluble this drug is. But watch this smaller piece here. A P-glycoprotein pump grabs some of it and sends it back out. Not the dominant story like it was for risperidone, but a real one. Distribution. And I want to be upfront here about sourcing. Olanzapine is widely described in the pharmacology literature as highly protein-bound, often cited around 93%. But I want to flag honestly that I couldn't pin an exact figure to BNF, Maudsley or Stahl's own text specifically, so treat that number as commonly cited rather than confirmed against these 3 sources. What is clear and consistent is that binding is high, which carries the usual implications, mostly in active reserve, with only the free fraction doing any pharmacological work. The oral half-life comfortably supports once-daily dosing, and here's a preview of something we'll cover properly later. The long-acting depot form of olanzapine behaves completely differently kinetically, with its own half-life measured in weeks, not hours. This is one of the single most important pharmacokinetic facts about olanzapine, and it comes up constantly in practice. Metabolism runs mainly through CYP1A2, with a smaller contribution from CYP2D6. Why does that matter so much? Because CYP1A2 is famously induced by smoking, not by nicotine itself but by the polycyclic aromatic hydrocarbons in tobacco smoke. Maudsley quantifies this precisely. Smoking can reduce olanzapine plasma levels by up to 50%, and the effect gets stronger the more cigarettes someone smokes. BNF reflects this directly in its own dosing advice. It specifically flags females, the elderly and non-smokers as groups where slower metabolism might mean you should start lower and titrate more cautiously. Flip that around clinically. A smoker who suddenly stops, say during a hospital admission, can see their olanzapine levels climb substantially within days, which is a genuinely common and under-recognized cause of increased side effects on the ward. Look at these 2 bars, same dose of olanzapine, 2 different patients. This one smokes and their level sits lower. This one doesn't, and for the exact same dose their level sits higher. That's CYP1A2 induction at work, and remember, it's the smoke itself doing this, not the nicotine. Same partial versus full check we run for every drug in this series. Olanzapine is a full antagonist at every receptor on this list. No partial agonism anywhere, unlike the aripiprazole family drugs. What makes this pharmacodynamics table distinctive isn't the type of action, it's the sheer number of receptors doing meaningful work simultaneously. D2 for the core antipsychotic effect, H1 for sedation and weight, 5-HT2A for atypicality, 5-HT2C for both mood benefit and weight gain, a full muscarinic panel for anticholinergic effects, and alpha-1 for blood pressure. Compare that list length with amisulpride's 2-receptor story from earlier in this series. That contrast is really the whole point of this slide. Dosing, Part 1. The standard starting dose is 10 mg a day, adjusted from there according to response, with a usual effective range of 5 to 20 mg and a hard ceiling of 20 mg a day. BNF specifically notes that doses above 10 mg should only follow a proper reassessment, not just an automatic step-up. And here's that CYP1A2 story showing up again directly in the dosing guidance. BNF tells you to think about lower starting doses and slower titration specifically in patients likely to have slower metabolism, women, older patients, and non-smokers, all groups with relatively less CYP1A2 induction. Food doesn't meaningfully affect oral absorption, so timing around meals isn't a major consideration here. Dosing, Part 2. Both hepatic and renal impairment get the same simple, cautious instruction from BNF. Start at just 5 mg a day, with cautious titration in the hepatic case. On interactions, carbamazepine, a CYP1A2 inducer, is predicted to decrease olanzapine exposure, so BNF says monitor and adjust the dose, exactly the same principle as smoking, just from a drug rather than tobacco. Levodopa is worth remembering too. Olanzapine decreases its effects, which makes obvious sense given they're pulling on the same D2 receptors in opposite directions. BNF says avoid or monitor. And now let's come back to our hook, with the actual BNF wording this time because it's more nuanced than Maudsley's blanket rule. BNF says to monitor blood pressure, pulse and respiratory rate for at least 4 hours after an IM olanzapine injection, and specifically to leave at least 1 hour between IM olanzapine and a parenteral benzodiazepine. That's a spacing rule, not an absolute ban, genuinely different in tone from Maudsley's rapid tranquilization guidance, which states the combination must never happen. Both are real, both come from credible sources, and knowing that they're not phrased identically is exactly the kind of detail worth having straight. Now the depot regimen, and this one genuinely stands apart from the other long-acting injectables we've covered in this series. First, administration, gluteal injection only. Deltoid isn't licensed and is less effective. Starting doses are matched to whatever the patient's stable oral dose already was. 10 mg a day maps to 210 mg every 2 weeks, or 405 every 4 weeks. 15 mg maps to 300 every 2 weeks. 20 mg maps to 300 every 2 weeks as the ongoing dose too. Maintenance doses, once you reach week 8, are generally a bit lower than the starting regimen. And here's a genuinely nice practical feature. Unlike Risperdal Consta, which needs 3 weeks of oral cover after the first injection, olanzapine's depot doesn't require any oral supplementation at all once you've confirmed the patient tolerates oral olanzapine first. But, and this is a big but we're about to spend a whole slide on, that convenience comes with a genuinely unique safety requirement. This deserves its own slide because it's genuinely unique to this formulation. Here's the mechanism. Olanzapine Pharmacokinetics is a very poorly water-soluble salt, designed to dissolve slowly for a sustained release. But if it's accidentally exposed to a large volume of blood, through an inadvertent intravenous injection, or injury to a blood vessel during administration, it can dissolve much faster than intended, and dump a large amount of olanzapine into the circulation all at once. Plasma levels can exceed 800 micrograms per liter, and the resulting picture looks like an oral olanzapine overdose. Confusion, delirium, marked sedation. The reassuring part is how rare this actually is. Under 0.1% of injections, one study puts it as low as 0.044%, less than 1 in 2,000. And when it does happen, it happens fast. The large majority of reactions, somewhere around 86 to 91%, show up within the first hour, with an average onset around 30 minutes. Very rare cases have appeared after 3 hours. Here's the genuinely important safety point though. There's no reliable way to predict who's at risk. Prior safe injections in the same patient tell you nothing about future risk. That single fact is exactly why the EU and UK product information mandates observation in a healthcare facility for at least 3 hours after every single injection, confirming the patient is alert, oriented, and shows no signs of overdose before they're allowed to leave. Look at this timeline. Most of the risk sits right here in the first hour. That's where the bulk of reactions happen. But watch, the observation window doesn't stop at 1 hour, it runs all the way to 3. Why? Because rare cases have shown up later, and there's no way to know in advance who they'll be. Contraindications and cautions here echo some of clozapine's own concerns, which makes sense given the structural relationship. BNF flags bone marrow depression, low white cell or neutrophil counts, hypereosinophilic disorders, and myeloproliferative disease as cautions, alongside paralytic ileus. CNS and respiratory depression gets its own specific mention too, which ties directly back to our hook slide and the IM plus benzodiazepine concern. Pregnancy follows the now familiar BNF pattern. Use only if benefit outweighs risk, with neonatal lethargy, tremor, and hypotonia reported after 3rd trimester exposure. Breastfeeding is a clear avoid here, since the drug is confirmed present in milk. And the dementia-related psychosis mortality warning applies exactly as it does across this entire drug class, no exceptions. Monitoring for olanzapine is genuinely more intensive than the standard antipsychotic default, and BNF spells this out explicitly rather than leaving it generic. Weight and lipids follow the usual baseline 3-month, yearly pattern for most antipsychotics, but for olanzapine specifically, BNF escalates that to every 3 months for the entire first year, only dropping to yearly after that. Fasting blood glucose gets its own tightened schedule too. Baseline, then after just 1 month of treatment, then every 4 to 6 months. That's meaningfully more frequent early monitoring than you'd default to for a lower metabolic risk drug, and it's BNF's own direct acknowledgement of just how significant olanzapine's metabolic risk actually is. Side effects. Same BNF and MHRA frequency system as always. The common or very common band is dominated by anticholinergic syndrome and appetite increase, both fitting neatly with everything we covered on the receptor slides, muscarinic and H1 antagonism respectively. Sexual dysfunction and edema turn up here too. Diabetes mellitus and breast enlargement sit in the uncommon band. And here's something worth flagging directly, because we specifically checked for it when covering amisulpride, and found nothing. Olanzapine's rare or very rare band does include a genuine hematological effect, thrombocytopenia. That's a real point of difference from amisulpride, and it echoes in a much milder way the hematological vigilance clozapine requires as standard practice, again reflecting their shared chemical ancestry. IM-specific effects are worth separating out too. Dyslipidaemia common with IM use and hyperventilation, diabetic coma, and ketoacidosis all appearing as uncommon IM-specific entries, tying back to the CNS and respiratory depression caution from a couple of slides ago. How does olanzapine stack up against the rest of the field? This is really where its whole personality comes together. Weight gain and diabetes risk sit at the very top of the class. Maudsley's own risk tier table places olanzapine in the high-risk category for diabetes and impaired glucose tolerance alongside just one other drug, clozapine. That's genuinely the worst in-class company to be sharing a table with, metabolically. Prolactin, by contrast, is comparatively mild, typically transient rather than the sustained elevation we've seen with risperidone or amisulpride. Sedation runs moderate to high, driven by that powerful H1 antagonism. EPS and akathisia are comparatively low, fitting with everything we said about D2 not actually being this drug's strongest action. And anticholinergic burden is genuinely present here, in a way it simply isn't for the cleaner drugs in this series. 2 closing angles. NMS, same rule as every other drug in this series, reported with olanzapine, and no receptor profile, however broad or narrow, grants any antipsychotic exemption. Formulation availability is genuinely excellent here. Tablets, a dissolving version, a short-acting injection, and a depot. But remember that depot comes with the PDSS observation requirement we just spent a whole slide on, so available doesn't mean free of extra safety burden. Worth restating the licensing gaps too. not approved for dementia-related psychosis, and that bipolar maintenance license is response contingent, not a blanket indication. And here's a genuinely interesting negative fact to close on. Despite structural kinship with clozapine and sharing some of the same bone marrow-related cautions, olanzapine does not require the mandatory ongoing absolute neutrophil count monitoring that makes clozapine so operationally demanding. That's arguably the single biggest practical reason olanzapine ended up so much more widely prescribed than its close chemical relative. Interactions. Pulling together everything from this deck, CYP1A2 inducers are the headline category. Carbamazepine is named specifically in BNF as decreasing olanzapine exposure, and tobacco smoking does the same thing through the same enzyme, by up to 50% according to Maudsley. Levodopa shows up again just as it did for amisulpride. Olanzapine decreases its effects, BNF says avoid or monitor, and the logic is identical. Shared D2 receptors, opposite direction of effect. Then there's our hook, restated with both sources side by side one more time. BNF frames olanzapine plus a parenteral benzodiazepine as a spacing requirement, at least an hour apart with extended monitoring. Maudsley's rapid tranquilization guidance frames the same combination as an absolute never. And finally, general CNS depressants and alcohol add to sedation risk, which matters more for this drug than for some others given just how strong its own H1-driven sedation already is. Quick fire round. Is D2 olanzapine's strongest receptor? False. H1 and 5-HT2A both outrank it. Do BNF and Maudsley word the IM plus benzodiazepine caution identically? False. Genuinely different in tone. Can smoking cut olanzapine levels by up to half? True. Does the bipolar maintenance license cover everyone with bipolar disorder? False. Response contingent only. Does the depot need 3 weeks of oral cover like Risperdal Consta? False. None needed, but it has its own 3-hour observation rule instead. Are there identifiable PDSS risk factors? False. None identified ever. Does olanzapine need clozapine level neutrophil monitoring? False. And are olanzapine and clozapine the two highest risk drugs for diabetes in Maudsley's own table? True. So back to where we started. Which antipsychotic carries an absolute rule against combining IM administration with an IM benzodiazepine? Now you know. Olanzapine, per Maudsley's rapid tranquilization guidance, and you also know BNF's own softer spacing-based version of the same caution. From here you've got the whole picture. A genuinely dirty, multi-receptor drug whose strongest actions aren't even at D2, a smoking interaction serious enough to reshape BNF's own dosing advice, a depot with a unique post-injection monitoring requirement, and a metabolic risk profile that puts it in a class of 2 with clozapine. If this helped, subscribe for the rest of the pharmacology series and drop a comment with whatever tripped you up.